Today, we're going to get started in just a moment. Welcome, everyone. Thanks for being with us today. We'll get started in just a few moments. Well, hi, everyone, and welcome. I am Michael Morella, Managing Editor at U.S. News and World Report. Thanks so much for joining us for today's webinar. We're exploring the topic of tackling the growing pediatric health threat of gun violence. Our experts will address the urgent need to tackle the public health challenge that has become the #1 cause of death for children and teens for the first time in U.S. history. Today's session is the latest installment in our Healthcare of Tomorrow virtual event series, exploring critical issues facing hospital and healthcare leaders across the nation. You can learn more about future programs and see video of past events at usnews.com/healthcareoftomorrow. We also are recording video of today's session, as well as live streaming on our Facebook, LinkedIn, and YouTube channels. I want to welcome today's panel, but before I do, one more note. If you have questions, we ask that you please type them into the Q&A feature in Zoom on your screen if you're with us live. Later in the discussion, our moderator will try to give voice to some of those as our time permits. So now I'm very pleased to introduce our panel with us today. They are Dr. Sandra McKay, Director of Population Health and Advocacy and Associate Professor in the Department of Pediatrics of the McGovern School of Medicine at UT Health Houston, as well as a pediatrician at Children's Memorial Hermann Hospital and Huffington Fellow with the Baker Institute for Public Policy at Rice University. Dr. Joseph Sakrin, Director of Emergency General Surgery, Associate Professor of Surgery, and Vice Chair of Clinical Operations at the Johns Hopkins Hospital, as well as a board member with the Brady Campaign. Dr. Chetan Satya, Director of the Center for Gun Violence Prevention at Northwell Health, Associate Trauma Director at Cohen Children's Medical Center, and Assistant Professor of Surgery and Pediatrics at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. And Dr. Regan Williams, Medical Director of Trauma and Associate Chief, as well as President-elect of the medical staff at Le Bonheur Children's Hospital. She's also an Associate Professor of Surgery at the University of Tennessee Health Science Center. Welcome to you all. Thanks for being with us today. And now I'll turn it over to my colleague and our moderator, Liz Whitehead, Managing Editor with the U.S. News Live Events team. Over to you, Liz.
Thank you, Michael. And thank you to our outstanding panel and our audience for joining us. I'd like to start with a story from the Washington Post from September 25th, 1994, about a shooting in Virginia. This was the lead. 2 Fairfax County teenagers were shot late Friday as they stood among a crowd of spectators watching a fistfight at an elementary school playground in Burke, according to police. They said they knew of no suspect or motive in the case. Now, one of those teens was shot in the throat and nearly died, except for the skill of the medical team who treated him. His name was Dr. Joe Sakrin, who is with us here today on the panel. Joe, can you describe what happened? How did that shooting change the trajectory of your life? And now, as a trauma surgeon and public health researcher, can you describe how this statistical picture of gun violence as a pediatric health threat has changed since then?
Yeah, well, thanks so much, Liz, for having me. And it's great to be here with this distinguished panel. And, you know, look, I just want to first start by just saying that it's so important that we're here to discuss what I think is one of the most important public health problems of modern time. And as you shared, I come to this conversation not just as a trauma surgeon currently at Johns Hopkins Hospital, but also as someone who's a survivor. And as you read, you know, in that little blurb that was on the back of the Washington Post, which, you know, was in the mid-90s before social media, that really, frankly, didn't get a lot of attention. I was a 17-year-old high school student. And you can imagine, you know, I left that morning as a healthy high school student. And then I was collateral damage after nearly being killed when I was shot in the throat with a .38 caliber bullet. And I think, you know, most of us as 17-year-olds, frankly, are living in the moment. We're not really appreciating the fact that you're mortal or even have any idea what you want to do in life. And I look back at that terrible moment, and of course, I wouldn't wish it on anyone, but the worst moment of my life also turned out to be the most impactful, because it inspired me. It inspired me to, you know, go into medicine. It inspired me to become a trauma surgeon. And frankly, my initial goal was really to try to give other people the same second chance that I was given. And what I realized as I started going down this professional path is that, despite how good we think we are as healthcare professionals, as trauma surgeons, or despite how incredible any one of our health systems may be, when someone comes in that's shot in the head, there's very little that we can do to bring them back to baseline. And in fact, the best medical treatment is prevention. And this was really, for me, the motivation that led me to explore developing skills beyond, the traditional path that clinicians have taken. It's why I spent a year at the Harvard Kennedy School of Government studying public policy, and most recently in the US Senate, really trying to understand the practical aspects of the legislative policymaking process. And I think the skills, Liz, that we need as healthcare professionals go beyond the bedside and the four walls of the hospital, and understanding the power of advocacy and storytelling has really allowed me to work at the intersection of medicine, public health, and public policy. And of course, here we are today, right, focused on the pediatric aspect of this public health problem. Gun-related injuries have become the number one cause of death of children and adolescents. I just want you all to think about that for a second. It's not car crashes, it's not cancer, it's not poisonings, it's gun-related injury. And the complexity of this public health problem, I think, lends itself to the fact that there are numerous aspects that comprise the entire burden of disease here. If you think about just, the number of children in this country that live in homes, right, with unlocked and loaded weapons, 5.4 million. Every day, right, you have 8 children and teens that are unintentionally shot in instances of what we call family fire, which is a term essentially to describe a shooting that involves an improperly stored or misused gun found in the home. So when we look at this overall global problem, people always ask, well, what's the one solution? And the reality is there is no one solution. It requires a multifaceted approach that cuts across sectors, right? Beyond, healthcare professionals, but including healthcare professionals, to try to really make and implement and tailor solutions in a way that allow us to go from simply trying to focus on human behavior, which we know in and of itself is not cost effective, and develop a system that makes it less likely for people to be injured. So I really, look forward to the conversation today.
Thank you. Thank you. Chetan, you've written about, before we move into solutions, I just want to get a bigger idea of how to identify all the elements of the problem, because you have to have good data and better research to inform the strategies that we need to tackle gun violence. Can you talk a little bit about that?
Absolutely. And, thank you to all my esteemed panelists here for being here. It's really an honor. Joe, your story, your journey has honestly been an inspiration to all of us. So thank you for everything that you do. When it comes to gun violence in kids or adults, it's important to set the stage that when we talk about a public health approach, right, we're talking about policy measures, we're talking about better surveillance data, understanding root causes, risk factors, preventative factors, and actual strategies that can prevent gun injury. We have a lot of gaps in knowledge when it comes to each of those elements. And as many of you know, that is because prior to 2019, federal funds allocated for gun violence research were banned. That has now changed. We are starting to delve into more and more rigorous gun violence prevention research. And I think this is absolutely critical. If you look at the turning point for motor vehicle safety, it came really when the CDC started to monitor motor vehicle injuries and deaths. And we were able to get better data, and we were able to answer these questions truthfully as to what works, what doesn't, and how should we implement this. This also includes the evaluation of policy. So we are definitely behind the ball when it comes to this on gun violence, but there is a ton of excitement right now because we have had these funds come in. This is a huge issue for many of our communities. And so to your point, Liz, I think there's some really big data gaps that do exist. One of the biggest ones I will say right off the bat is data infrastructure and the surveillance of injuries in the first place. We have pretty decent data when it comes to gun deaths in this country, but we have very poor data when it comes to those who are injured non-fatally by guns in this country. right? Data tends to be siloed within law enforcement, hospitals, public health agencies. And for us to communicate with one another and to get a real picture of what happens to an injured patient is absolutely critical. In many areas right now, we don't know if a patient comes in who's injured to my hospital, what happens to that patient next? What happens when they go to a community program? Is it actually effective or not? So that really speaks to, I think, the first and foremost priority in the research world is to get that better data, that better, surveillance, so to say, just like we did with other epidemics, COVID-19 and so on, to be able to answer in real time some of these questions and to evaluate what works and what doesn't.
Thank you. Regan, the primary drivers of gun violence, as Cathan and is suggesting, are very complex, and they vary from community to community. Just to sort of set it up a little bit, can you talk about what you've seen at Le Bonheur in terms of Memphis, the different drivers of gun violence, just so we can understand how varying the causes could be within miles of each other?
Yeah, so when we noticed the increase in gun violence, we really did try to take a public health approach, but for our own community. So we looked back at firearm injuries in children for the past 15 years, and we were able to really determine etiology because we have a social worker in our children's hospital that sees all of our firearm injured patients. And what we found at that time was actually about half of the patients were victims of accidental injuries, and about half of the patients were victims of intentional injuries. And when we looked into that even further, the accidental injuries were mostly firearms that were not safely stored, so were found in the home. And these patients were more likely to be injured either by themselves, a family member, or a friend. And about 92% of them were within the home. But when we looked on the other side, which was our intentional injuries, most of those patients, about 80%, were injured in drive-by shootings. So these are often children that are walking down the street, or they're in their house eating dinner, and their house is shut up, or they just get caught in the crossfire of what's going on in their community. And so we really determined then that we had to have two different approaches to firearm injuries in our community, because half of them were related to unsafe storage, and the other half were really related to community violence. And then as the pandemic hit, we continued to prospectively look at all of the data, and it actually shifted. So our accidental injuries stayed exactly the same during the pandemic, but our community violence and our intentional injuries increased a lot, actually almost 30% from the pandemic itself. And so though we're still looking at, say, firearms storage and how can we teach families and communities to store their guns safely, we're also really shifting to look more into community violence, because that's the largest driver in our community right now.
Thank you, Regan. And I'd like to get into both of those points. And I guess I'll ask Sandy if you can start with the safe gun storage initiatives. Children's Memorial Hermann is working on that, but it's predicated, I think, on the physicians as trusted messengers. And in thinking about it, they're not just trusted messengers as helping keep families well, but also they're members of the same community that share those experiences, which helps the conversation. Can you talk about what you're trying to do in your community with safe gun storage, with screening for risk, and how you can relate to patients as a member of that community, as a wife, a mother, a Texan still in a state coming to grips with Uvalde?
Absolutely. Yes. So what we've been doing within our clinics is, living in the state of Texas, we know that we have a different relationship and culture around firearm ownership. And it is one that we need to approach with a different mechanism. And within our patients, we've done a lot of work surveying and understanding, what is it that our patients want? And looking at our patient population, what we understand is physicians may not be the trusted messenger that we think that we should be. We know our patients trust us when it comes to, looking at recommendations for, safe sleep or for what to do with a cold. But when it came to understanding about firearm safe storage, we were not the top rated person that they would go to when they had a question about safe storage. It was law enforcement, family and friends, and firearm retailers. And so what we've done is we've taken a little bit of a different approach in partnering with our firearm retailing community to say, let's look at what the messaging should be and who should be delivering that message within our communities, because we know that physicians should be utilizing proper language when speaking with firearm owners, making sure that we are using language that will resonate with them. So that way we can help support firearm owners to, want to shift that behavior change to take that firearm from being stored loaded and unlocked into a locked position. And so that way we can really bond with them. And, being a firearm owner myself, I can help, bond and form that relationship with the community because I know where they're coming from. I know where they understand. And even after Uvalde, this was a ripple effect that went well beyond the local Uvalde community. It really brought home so many of our patients, even within our local area. Our physicians, our communities, even our firearm owners were really just impacted well beyond the initial Uvalde community because it was not anything that even firearm owners ever wanted to see happen within another community. And people were reaching out saying, what can we do to not let this happen again? And how can we help shift some of these behaviors? And so we're looking at mechanisms that we can do to shift that messaging to say, well, we need to make sure that we have safe storage within everyone's home. And how can we get a message that will resonate within the community to help shift behavior change?
Liz,
Go ahead, Joe.
I just chime in on this because I think Dr. McKay's point is so important. And I think, she's correct. When you look at the data that's out there, the data would suggest that, physicians are maybe not trusted public messengers on this. And I would say, I think we have to take that data and look at it very carefully and ask the question why. And I think when you ask the question why, what you tend to find is that healthcare professionals are often maybe haven't traditionally been trusted messengers in that role because they haven't been empowered with the knowledge and the skills to talk about this in a way that's objective, that's non-judgmental. Because when you look at healthcare professionals just globally, actually society trusts us quite a bit. And so I think we have to figure out as kind of healthcare professionals and medical centers, right? Of course, I think a lot of us here and across the country believe that we have a role in firearm injury prevention that cuts across kind of, the focus of clinical care and has an educational component, right, for the next generation of healthcare workers, has a research component, has a community engagement component. And you can imagine that clinicians who interface with patients have the opportunity to identify those at risk of firearm injury and provide counseling to mitigate those risks. And those opportunities are not, they're safe storage counseling, but they're also lethal means safety, supporting families in the implementation of extreme risk protection orders, right? All of these different facets. But I think we have to do a better job of preparing healthcare professionals with how to do this in a way that's non-judgmental. And I think we're at the beginning steps. We have people, like Dr. Sathya and others that are working on this across the country to figure out how can we develop, these toolkits and these components to be able to empower folks and to be able to empower them to do it in a way that we do then become trusted public messengers, so to speak.
Oh, Joe, I think you're absolutely accurate on that. I think, one of the things that we've done here in Texas is we've developed workshops to train, pediatric physicians, and we've been doing this, since even before Parkland, and even integrating it not even within like pediatric residency training programs, but even looking at it from undergraduate medical education. And I think that's really the cusp of looking at it is, when do we start training our trainees? Do we wait till residency? But I think we really need to start thinking about that undergraduate medical education training. We teach them to ask a lot of really personal questions, but when we've looked at some pre and post data, by far the majority of people who are asking those questions, more than 80% aren't firearm owners, are uncomfortable even starting the conversation. So if you're not comfortable with it, you're not going to ask questions in a culturally sensitive manner, and you're going to walk in and maybe potentially say something that may not resonate with a firearm owner, and then that's not going to deliver you as that trusted messenger within that clinical encounter. Or if you're not comfortable, you may skip it altogether. And so a lot of my work has been, training physicians in training to ask that question of, how do you store your firearms in the home? How can we help them do that harm reduction strategy so that way we can shift that behavior change within that home setting, and even helping trainees feel a little bit more comfortable asking that question and teaching them a little bit about basics of firearms so they know a tiny little bit of knowledge so they can feel empowered. So when they have that conversation, they don't feel uncomfortable with it.
I don't know if we lost Liz. It looks like her screen is frozen, but I totally agree. And I guess the one thing that I would just add to that, since we have a minute, and maybe Dr. Williams and Cynthia have some other pieces, but I think, when we look at like violence prevention interventions, whether it's like one-to-one counseling or large scale public campaigns, we have to, I think, and you said it nicely, look at all the different facets. So it's part of it is considering the audience, but also the messenger and the message. And, like I heard, not to pick on Dr. Williams, but I heard, the term accidental, being used. And as Liz knows, we had this whole conversation when we were planning for this. And I said, like, listen, like, I never use that word because it implies that it's not preventable. So all of these like components and how we kind of come together and engage, stakeholders like firearm owners are going to be so critical. I think the way you described, Dr. McCain, that's going to be important if we really want to think about kind of a census, and based approach to really tackling this and moving the needle forward.
Yeah, and just to, I think Joe, Dr. Sacker, what you're good. You're good with Joe. I think we've. But we're focusing on physicians, as you mentioned, and healthcare professionals. But we can't forget that healthcare institutions are not very trusted, particularly by marginalized communities. Right? There's a lot of history there. There are good reason not to be trusted in many elements, and to build that trust, as Dr. Williams knows as well, it takes a lot of effort. And I think we have a lot of inherent biases ourselves. You're absolutely right. We're not trained, like you mentioned, Dr. McKay, in how to deal with those biases and how to know, who's a trusted messenger, who's not, and how to have those conversations and be honest about our own biases. And so to really change it all, I really do think, to your point, the culture change across the institution is critical.
Absolutely. I'm looking at the chat here, and I think we need to look at across the spectrum, not just physicians, but we can look at nursing. Some of the work that we're doing is also look at how we can train even firearm retailers to deliver that culture of safety messaging. And so some of the work that I do is doing partnership with our firearm retailers to deliver suicide prevention counseling, as far as like delivering information about suicide prevention at point of sale, as well as doing that safe storage counseling at point of sale. We're learning all kinds of information down here in Texas because there's even this little bit of bias, because firearm retailers assume that firearm owners should know about safe storage. They think that everyone knows that you're supposed to lock up your gun, so why don't you? And so we've already uncovered a lot of opportunities for intervention and improvement within just some of this preliminary research that we've done, and even just how we can improve our messaging within there. So moving that needle forward with multiple coalitions and partnerships, and then how we can take those coalitions and partnerships and even move that onto policy too. Because there's multiple opportunities for policy around, what information should be supplied to people at point of sale. I mean, there's a really, if there's real information that should be supplied at point of sale. The ATF requires child safety information to be distributed. If anyone's ever seen that information, it is very legalese. There's an opportunity for us to improve that, to make it an information that could be usable to families, that would be, much more delivered in a more health communications efficient approach, rather than reading like you're reading a law book, which, let's face it, I wouldn't read a law book. So I mean,
Dr. Williams, I think you had a comment, right? Also.
Yeah, I was just going to say, I think when we talk about having a conversation, we have to normalize talking about guns and firearms. Very similar to Sandy, and I'm from Tennessee, and that was like a thing you just didn't talk about. But I've been talking about it for 3 to 5 years now, and making it not a taboo subject. And I think that same thing goes along with mental health and suicide. Like, we've got to talk about it. We've got to let everybody know that, we always talk about just keeping kids safe. So it's not about taking your guns away. It's about keeping kids safe. How can you keep kids safe? You can store your gun safely. You can work within the community. So I think it's really a whole culture change, that certainly in some of our states, it's taboo to talk about guns at all. It's not even discussed. And so I think the more we talk about it and the more we normalize it, the easier it is for everyone to be able to have those conversations.
I think that's right. And I think, just to go back to something in the chat, I saw that Marianne put in a piece about nursing. And I think we 100% agree that nurses are trusted health professionals. And this is why I made the comment that in general, healthcare professionals, this is why I use that term, because it's not just physicians, but healthcare professionals in general are trusted professionals in society. But when you break it up among different issues like firearm injury, as Dr. McKay pointed out, some of the data demonstrates specifically for that aspect that maybe we're not. And that's why we were trying to peel back those layers as to, well, why is that if we're trusted in all the other different pieces? And I think that it's been a nice discussion.
Yeah, and I just want to add to that, because I think it's really interesting to, we do often, you see a lot of physicians having these conversations, but we can't do it without the whole clinical team. And, one of our implementation projects is obviously at Northwell is to universally screen. So to ask every single patient who comes into our EDs questions about firearm injury risk, including access-related risk and violence-related risk. And I will say, Dr. Williams, too, even in New York, it is taboo to talk about this. It is not an easy, even here, obviously not as much, but there is a lot of resistance to that. By doing that process, too, the more you can think about integrating screening and intervention into your clinical workflows, and think about a comprehensive team-based approach, not only does it improve your success of implementation because you have multiple folks involved, but it also educates and allows everybody on the team to be engaged. Because the issue is that when you try to scale some of these programs, if you don't have everyone engaged, you're going to continue working in a silo in your own institution. So I'll give you an example. When a patient comes to Northwell, the nurses do the pre-screen, just like they already screen for suicidal ideation, substance use, and so on. And then an intervention is performed for those who screen positive by either a physician, social worker, an ACP, a resident, or a health coach, a variety of different folks. And I will tell you, having diverse cohorts involved, you'll be surprised at just how much more robust that program can be. So I think that was a great question.
Yeah, and I think, oh, sorry, go ahead, Michael. Are you our moderator?
I was I wanted to just step in and ask the question directly, though I think you all are getting to this as Liz gets reconnected. Can you just kind of dig a little deeper both into these hospital-based violence intervention programs and how you can use data and turn that into action? And again, I don't want to disrupt the conversation. I think you all are getting in that direction, but I wonder if you could kind of talk a little bit about some of the examples you're learning, not only in the places where you work geographically, but at your own institutions, and just kind of shed a little additional light onto that for our audience members who are at, whether they're at children's hospitals, broader systems, and so forth. Dr. Williams, do you want to start?
Sure. Yeah, I can definitely tackle that one. So we definitely use data to start our hospital-based violence intervention program. When we started looking into this, that was really one of the only things that had been published that was found to be effective. But it takes a lot of money and a lot of resources to do that. And I think everyone's going to be in a situation where your hospital doesn't have infinite funding. And I think that sometimes the patients that we're targeting are often not focused on as much as they should. And so we actually started this mission with looking at adverse childhood experiences. And we looked at our trauma clinic and found that 30% of our children had adverse childhood experiences, and it was up to 40% in the teenagers. And with that data, we actually were able to get a local grant that funded mental health counselors coming into the hospital. That became really interesting because our mental health counselors developed such a relationship with all of our patients that they really identified some areas and some needs. And it was actually through that information, as well as really through a lot of media. I was talking about firearms a lot on TV, that the mayor's office actually reached out and said, hey, we think that we want to start this program and we think that you should help us. And that was kind of serendipitous. We just were looking at adverse childhood experiences. We got mental health counselors because we thought everyone needed it. We'd been trying to get a hospital-based violence intervention program for a while, but it all came together where we were able to get the funding from the city, which is really important because the city has some connections within each of the communities that really help our program to be more effective as well. So I do think you have to start with the data and go from there.
Yeah.
Michael, you want to pick me up where we are and I can continue on? Sorry, y'all.
No, yeah, Joe, if you want to.
Yeah, it's okay. Liz, don't worry. We got you. So just to piggyback a little bit on what Dr. Williams is talking about, I think, those have, of course, been incredibly critical, and we've seen, the hospital violence intervention programs pop up across the country. I think as Dr. Williams kind of, alludes to, part of the problem is that there's these ebbs and flows in kind of funding cycles. So you can imagine some of them come, some of them go. And when we think about this kind of globally, right, part of the reason I think this is so important is because one of the biggest kind of aspects that we're tackling, especially in urban communities, is, this concept of like the social determinants of health. And just to kind of like level set, right, these are non-medical factors that influence health, right? So it's conditions in which either we're born into, we grow, we live, work, kind of, and it's the broader set of forces and systems that shape the conditions of daily life. And when you look at these, right, they represent, this negative impact on health and inequities. And we have really, I think, we do such a great job as healthcare systems in kind of delivering this acute phase of care, but we really need to focus on what happens when patients leave the hospital. And there is such a broad impact on violence and other chronic diseases, that some were outlined by Dr. Williams, right? That we have to really do a better job of kind of peeling back those layers. There's been a lot of approaches to tackle that, one of which, I can just briefly mention is this concept through the American College of Surgeons called ISAVE. It's improving social determinants to attenuate violence. And this is kind of a multidisciplinary work group that Dr. Rochelle Dicker has really been very involved in. And really, they're trying to address the root causes of violence by really identifying 4 different areas. One is trying to develop and implement a trauma-informed care curriculum. The second is trying to identify different strategies for social care into trauma care. The third is trying to really figure out how do we invest in disenfranchised communities. And then the last is being able to advocate to support all of these different strategies. And I think for a long time, we looked at advocacy as a dirty word, but really it's not. And as individuals that are at the center of taking care of these patients, we have, I think, both the opportunity and the responsibility to advocate for evidence-based policies that we think are going to not just impact the outcomes of our patient, but prevent them from ever becoming our patients.
So I just want to pause for a second. So there's when we're talking about the pediatric population, there's children and teens as victims, and there's children and teens as sometimes the users, the causes gun violence. And there are kids who are in families where they have gang member, older siblings, and it's how do you break this? And I just want to tell you a story to illustrate how important these violence interruption programs can be. So nearly 3 years after Joe was shot at a Virginia playground, a recently retired Army Master Sergeant, David L. Williams, a combat veteran, was walking at dawn to meet his carpool, taking him to a new job in Fort Irwin, California. David Williams never got to work that day because a 16-year-old with a history of violence fatally shot him in a mugging for the $1 or $2 in his pocket. His death devastated his 2 children in a loss that still echoes today. He should have become my father-in-law. He should have lived to see his kids grow up, marry, and have his grandkids. That chance was taken away from him. But tragically, that story has been repeated thousands and thousands of times for families across the country. And so one of the things I know, Regan, you've been focusing on is what age do we try to target these kids to make a difference? Because this 16-year-old was a hardened criminal at 16. What do we do? What works?
I don't think we totally know what works. Most of the data on the hospital-based violence intervention programs really include ages 14 to 24. And I really think that by 14, a lot of those patients are so far gone, it's really hard to rehabilitate them. And so we really want to focus on 8 to 12, like how do we support individuals in these disenfranchised communities to keep them out of that cycle of violence. And so we're really working on primary prevention, keep them out of the hospital, keep them from getting shot, and supporting them and doing things they love, allowing them to find interest, keeping them in school, and giving them a chance to thrive. And I think it has to be done early. I think that when you wait, it's gone. Their scars and their adverse childhood experiences are so severe, it's really hard to rehabilitate them.
And that plays into what you were saying, Joe, about the social determinants of health. And Sandy and Chafin, if you want to get in on this, is intervening in these families early. And it's also, is that the role of the pediatricians and the health systems, with these threat assessment or the, risk assessments? Can you pick some of this up earlier and get some program help in there to help these families and these kids?
One of the things that we do as general pediatricians is that we have to continue to screen children and families universally. And one of the things that we've done, with Children's Memorial and with UT is we've implemented a universal screening process for social determinants of health for all children at all well child visits. And that we're also going to be doing that for all children who present into the hospital for inpatient visits, just universally, because we have to start universal screening. And not everyone does this in pediatrics, but it is definitely the movement and the shift, because we can't make assumptions and we can't wait until we start, looking for children to start having struggles with truancy or deficiencies in schools and start showing signs. We have to start when they're young and when they're 12 months old and 18 months old, and just start screening families and saying, are you struggling? Are you having issues with, food insecurity, transportation insecurity, financial insecurity? And how can we help your family? And how can we help you meet the needs to help you raise your children and grow and connect you with your community-based resources to help you thrive within the setting where you live, work, and grow. And that is where pediatrics needs to continue to move to, so that we can help support children and families.
Ethan, can you talk, and then Joe, can you talk a bit more about how difficult, or not how challenging it might be to set up screening? I mean, how do you do it from community to community? What is effective screening? What are you asking for? What would be the action plans that you set up based on what you find in the screening? How complex is this?
It's not really that complex at the end of the day. It is just simply asking the questions. Again, whether you're talking about social determinants of health screening, firearm access screening, or violence risk screening, like I was talking about earlier. And when I say violence risk screening, I'm referring to something called the safety score, which is a validated tool that has been shown to predict gun violence in at-risk substance using youth. But we are expanding that type of tool. It has questions such as, how many times in the last 6 months have you heard gunshots? How many times in the last 6 months have you had a gun pulled on you? These are questions that are highly predictive of future gun violence, with the hope, again, that we can offer these resources before a patient comes in with a gun injury in the first place. It's just asking the question. But for decades, really, if you look back, we have known for a while that, for example, just asking about access and offering safe storage counseling, or inquiring about social determinants of health and actually offering community resources can make a difference. But very few providers actually do this as part of normal care, as part of usual or routine care. So to change that is the part that takes effort. And that's why, all the panelists mentioned earlier, education. Education is key. We don't have medical school courses on this. We don't have undergraduate multidisciplinary courses on this. Even at an institutional healthcare level, one of our big pushes has been, how many hospitals have a center or a pillar or an institute for gun violence prevention, versus how many children's hospitals have an institute for cancer prevention or heart disease prevention. This is, again, the leading cause of death in kids. So you really need to start at that level of education very early on to inspire the next wave of providers, clinical team members who are educated in this area. Once they're educated, asking the question becomes that much easier. And you need institutional support. We can't be leaving our frontline workers by themselves to ask these questions, because it is the whole culture of the institution that needs to come together on this.
Thank you. Joe, did you want to add a point?
Yeah, no, I think that covers it nicely. I kind of added some stuff while you were off regarding that. I think they summed it up really nicely. They summarized it pretty well.
If I can just get back quickly to the institutional support part, and the how many different, does it come just at the top of the CEO level? Or, I mean, where do you get the support to set up these programs to work off the screening, to address the social determinants of health? How should it be organized?
So I can quickly comment on that, and maybe others have a thought about that. But I think this goes back to some of the stuff that we've been hearing, which is trying to figure out how do we break down the silos in cities, because yes, of course, we want the CEOs and the leadership of healthcare systems involved, but that in and of itself is not going to be enough. So when you think about sustainability, long-term kind of interventions and capacity building, that requires, healthcare systems to be integrated into work with, the mayor's office, the public health department, law enforcement, right? Businesses, all these different sectors coming together to not just share kind of the data infrastructure, but also to make this a priority where they're sharing resources and, most importantly, building the necessary trust that is required in communities. And I think community is probably the most important piece of this entire puzzle. As Chafin mentioned earlier, I think in a lot of the communities, there's a distrust that exists between kind of the healthcare system. So the short answer is I think it needs to be all of us. But yes, we do look for hospital leadership supporting this in very meaningful ways as well.
Yeah, I would
Sandy?
absolutely echo Joe on that. We need buy-in and support from hospital leadership. And I think that can set the tone for where your programs go. And that was one thing that we saw in a shift here at Children's Memorial, because, we have a core, very active, passionate, engaged folks that are dedicated in injury prevention and violence prevention. And what we saw was, especially after Uvalde, a shift in a desire to want to promote firearm injury prevention. And that came from the top in our leadership. And then they decided to dedicate, financial resources and said, we see this as a community problem and we want to engage. And they dedicated resources to do a community-based intervention to distribute 10,000 cable locks within our Houston greater community, and said, we're going to put our money where our mouth is and just do it. And, we're going to engage with our community and start working towards, firearm injury prevention in a meaningful way and start implementing more programs. So if your leadership is engaged, then you can start really having more resources to make greater impact. And that's really where it needs to come from, because it sets your tone where your hospital can move forward.
Regan, what you all have been emphasizing also is that you can't do it alone. The hospitals and health systems can help lead this fight. They can propose, they can set up their own programs, but it's going to require community partnerships. It's going to require every element of the community joining together. Can you talk about a couple of the partnerships that you're doing at Le Bon or that you think are particularly promising or interesting?
Yeah. It definitely takes a community. We see the patients, but we certainly don't see where they come from or where they go. And I think in our community, I'm sure all major cities, there's all these small little communities, and there are siloed groups that are working within the communities. And I really see the hospital as being a convener of all these groups, so that we actually had a community summit where we brought everyone together. We met a ton of people. We learned a lot about what was going on. Everybody learned a lot about each other, which was really important. And then with us, we've really partnered with the city, that has a group violence intervention program, but then our county and our health department has a cure violence model that they're doing. And then we also have a couple small programs that are lived experience mentorship programs within each of the communities that we're working with. Those have been really great, because as much as I think I know what the community needs, I don't really know what the community needs. I don't know the best way to teach them about firearm safety, and I don't know how to treat all their social determinants of health and to support them. But the people that live in the community, they do, and they have a lot of insight. So we've really partnered with a lot of groups in the community. We're bringing them in the hospital. They're at all of our meetings, and we're just asking them, like, what can we do? How can we help you? One thing that we do really well is we're really good at gathering data. And some of our community organizations are really good at doing the work, but they're not as good at gathering the outcomes to support the grant that continues to fund their work. And so I think that's one way that the hospital or the academic center really can support the programs within the community that are doing the great work, but need the continued funding and the continued support to grow and continue their work.
Sandy, you mentioned a quite interesting program early on, and please feel free to mention another one, but can you talk about the partnership with the gun retailers, which seems counterintuitive, but then it's not, because they're the ones who deal with the community you want to talk to most. So can you talk about what kinds of inroads you've made, what kind of reception you've gotten, and how you think it works?
Yeah, so I mentioned a little bit earlier about it where we are partnering with our firearm retailers to do point of sale counseling on safe storage. And so working with them on understanding that not only the language and the messaging, but so that they can do some safe storage counseling at point of sale. But we've also done a ton of focus groups, not only with the firearm retailers, but with firearm owners to learn about that messaging, and also looking at that approach for suicide prevention, material distribution with point of sale as well. And the other thing that we're looking at with our firearm retailers is talking with them about temporary out-of-home voluntary storage, because Texas as a state does not have any extreme risk protection order. And in this state and in this culture, that is not something that is necessarily palatable to our firearm owners nor our politicians here. And that is also something that looking within our firearm retailers, we have several of our firearm retailers who offer this service where you can have your firearm stored within their retailer community, for a small fee for service where they can store your firearm out of their home on a temporary basis. And so this can be a tool, another opportunity for us to be able to utilize, with someone struggling at home where they can have temporary out-of-home storage. So that way, if there's someone like grandma and grandpa's having their grandkids over for the weekend, or, if there's someone who, needs to really have that firearm removed from the home because someone's struggling, there's another place where we can then work within our communities to have an out-of-home temporary storage option. So our team is actually trying to work at calling all the firearm retailers within the state of Texas, but it's a slow process because there's a little bit many of them. And so there's a lot to call. And we're trying to map out the entire state so that we can provide that resource not only to the firearm owning community, but also to our healthcare providers. So because when we surveyed patients within our clinic, we asked them, how many of you would know what to do with your firearm if you had to remove your firearm from the home for safety purposes? And 40% of people said they would not know what to do. And that's a huge concern for us as pediatricians, because we want to make sure that in those times of crises, our families know what to do, especially if they need it to remove their firearm from their home for safety purposes.
Sandy, just a quick follow-up. So do you find that the retailers, have you been able to make partnerships with groups of retailers to sort of help you get the message to the next group of retailers?
Yeah. And, surprisingly, they're very engaged in this. They see themselves as the experts in firearms, and they care about safety, and they care about the safety of the people that they're selling their firearms to. And this is an area where I think the phrase was used repeatedly to us that, you guys in almighty academia make all the rules for us and you never come talk to us. And I'm like, I'm here talking to you now. I would love to hear about what you guys want to know and what you think is important. And they're very insightful. And they really do want to partner with us, because it's when it comes to safety, they see themselves as the experts in firearm safety, and they are. They sell firearms to people. They talk to them about safety every single day. And I think there are multiple opportunities for us to partner with them so that we can have that shared mission and that shared vision of, having people store their firearms safely and be safe in their homes. Every single firearm retailer that I've talked to said, we do not want to be the retailer that sells that firearm to the next Uvalde shooter. And, one of the asks, they had several asks for us. One of the very clear asks that they had was, we would love to get some training from you in healthcare to learn about what are the red flags when someone's struggling that we should be looking for in that point of sale. We are not healthcare professionals. We don't know these things. Maybe you guys can teach us. I mean, there's a lot of information and exchange that can go back and forth. And that's been really very rewarding for us as a research team, because I think this is an area that we can really partner with, especially when you come in with an open mind and you're willing to listen to your community.
And isn't this part of the message that if people can separate politics and just focus on everybody wants to be safe, and have your guns, hunt, whatever, but everybody wants their children to be safe, their families to be safe. And if you can reach people on that level, then you can open their minds to figure out how to go about this. Joe, were you going to add?
Yeah, I was just going to say, I love those points that Dr. McKay mentioned. And I would say just two things. One is, I think she had mentioned earlier that you're a gun owner, right?
Yeah.
And I think that, of course, helps bridge, that gap. But the other piece is that, when we think about how we talk about this, I think the words that we use are so critical, and the way that I've kind of, tried to approach is this is about responsible gun ownership. And I think when you start to really kind of think about how you're communicating the message, who the messengers are, like we've discussed, all of those different pieces together allow us to get at a place where we kind of build on the commonality that exists among us as Americans. And I think that often doesn't get seen because, you see all the kind of divisiveness that's happening on social media or on the evening news. And the reality is that most Americans actually agree, on a wide variety of these pieces that we're discussing today. No one wants to see children being shot and killed. No one wants to see these school shootings or the urban violence. And so, to be effective, right, it's not just about the right idea, but it's also about having the right strategy and approach.
Absolutely. And I think also looking at the avenues where you can improve your effectiveness and looking at the chat, it is a requirement from firearm sales that all handgun sales have to have child safety materials distributed with point of sale. That's a requirement with every handgun sale. How can we improve that process? That's a great opportunity for us, especially using health communication skills to say, what can we do with that required, ATF point of sale that you have to do, that they are required to do by federal law? How can we improve that process to make it a more effective process, a process that's actually going to shift behavior change and not make it, here's your handout process?
Chaitin, I know you want to get in on this.
Yeah, no, I'm just saying, just with respect to firearm safety too, health communication is critical, just as mentioned. And I think, we just launched a huge New York-wide campaign on asking parent to parent, around the idea that when you send your kids over to someone's house, you should be asking about weapons being stored safely. The intention is not to take guns away, but to have them stored safely. And, the reception has really been outstanding. And I think we sometimes don't realize that for a lot of Americans, and just people in the community, they don't necessarily understand the risks of having a gun that's unsecured in the household in the first place. And they don't also view this as something that they should typically ask about. When you view it from that lens, as a parent, you obviously ask about child safety gates, drowning avoidance, seat belts. Why wouldn't you ask about an unsecured weapon? And I think it is starting such a incredible conversation. I know Dr. Saccharin's worked on similar ask campaigns with Brady. It is that type of dialogue that helps us find the common ground. Because you're absolutely right, Dr. Saccharin, everyone else here. Everybody wants the same thing. Unfortunately, it's become a lot of them versus us. It is our duty really not to vilify any group here, and to understand that everyone has a part to play. We work very strongly with gun owners. They actually inform all the education that we give to our providers on this type of counseling. So, we need to work with all community members to make this work.
For hospital and healthcare leaders who are in the audience who are looking to build up their programs, actually, Chaitin, I'd like to come back to you and then have the rest of the panel also come in. Can you talk about the sharing of best practices? It seems that the more that you all can talk to one another and share what works, because there's so many different communities, and yet across the United States, there are communities that do overlap with each other where they could apply some of these lessons. Chaitin, can you talk about Northwell Health's efforts in this area? And then I'd love it if everybody else would add their thoughts.
Yeah, we have a learning collaborative that was launched in a very, cross-hospital fashion in April 2020. For that exact purpose, Liz, was to bring hospitals together who are either doing work already in this area or who have never done work in this area and want to learn from others. To have a sustained dialogue in a monthly fashion, to develop best practices, share those best practices, and then implement programs and share their experiences. Because at the end of the day, this is about implementation, not just activation. So that has been one of the big pushes. Through that collaborative as well, we work a lot on mobilizing other CEOs and healthcare leadership to act on this. I will say that there's kind of two streams. A lot of healthcare leaders, when we approach them about this, either they're just tremendously busy with a lot of real issues, real struggles that hospitals are going through right now. Peri-pandemic, financial struggles. There are a lot of other considerations that they have to take under account as hospital leadership. So there's a cohort of that as well. And I think the more we collectively sustain the dialogue, get more people to join in, hospital leadership at other hospitals really takes note and wants to then join in. And then there's a significant cohort that, just like our concerns that we brought up today, they have real concerns about speaking very openly about gun violence prevention. It could be, that they sense reluctance from their boards, that they just don't feel that it's the right issue to talk about this time. This has been a thing that comes up among hospital leadership way more than you would think. And I think, again, the more we sustain this and talk about this as a public health issue and show that other leaders are doing this and activating around this, the more that those other folks come to be a part of this. So
thank you. Regan, I know that you've tried to, at Le Bonheur, try to work with some hospitals in your network. Can you talk about how you've tried to share best practices?
Yes. So we are really trying to collect data as we do all this work to figure what works and what doesn't work. There's a lot of work going on in our community, but as I alluded to earlier, some of it, they don't know how to collect outcomes, and so we don't know what works and what doesn't work. So as we start our mental health counseling program, we've been really collecting a lot of data as to who are the most at-risk populations, and then how do we apply our mental health counseling specifically to them. And we're trying to also work through our corporate levels. So we're a big hospital system. We have 5 or 6 hospitals within the community. And so if we can develop programs at our children's hospital where the volume isn't quite as large as it is at our adult hospital, then we can take what we learn at our children's hospital and really apply it to the adult hospitals where the volume is much, much greater. And it can sometimes seem insurmountable at those hospitals. But we know if we work out the kinks, then we can really apply those to the larger volume and have a greater impact.
Thank you. Sandy, can you talk about how you're talking to perhaps other hospitals in Texas?
Yeah, absolutely. I think some of the things that we're looking at is that we're at the Texas Medical Center, which is the largest medical center in America. And we're within, the greater Houston area, which is 4th largest city in America. And so looking at how we can partner with our regional hospitals here, and not only that, also within our city, to where we can look at leveraging those data sets, so we can look at where we can make those biggest program developments and access those. And so not only just within our hospital system, but within our community hospitals, within our system. So, we've got several community hospitals that kind of feed into our big Texas Medical Center as well. So how we can leverage those to make those impacts in our communities, to understand where the firearm injuries are happening, understand how we can help develop those programs, so that way we can help train people at our local hospitals, train people within our main Texas Medical Center, collaborate with the hospitals within the medical center, so that way we can be effective in developing those programs and those interventions.
Thank you. Joe, before we move to this, everybody's final thoughts, do you want to add to this idea of the partnerships with other healthcare institutions and how to share best practices more effectively and more efficiently?
Yeah, I mean, I think the one thing that I would just say is that right now there's a lot of interest has been described, right? And with that interest and with the expansion of the research that's happening, one of the things that we're finding is that a lot of different systems and groups are coming up with, their own toolkits, their own processes, sometimes duplicating or replicating efforts. And so I think what I would personally like to see, and I think would be most effective, is to figure out how do we reduce the variation that exists across healthcare systems in America, because the reality is it's just such a waste of resources for me to work on something that is maybe perfected and being done better elsewhere. And I think part of that requires this open line of communication, and it's starting to happen through different forums and collaborations. But that's one of the things that I think we really need to kind of wrap our heads around it, because otherwise, people are going to be even more confused than they currently are, because you go to one website, you see, hey, this is what you should be doing. And then you go to another and it's a completely different toolkit. So I think we can really find a better way to kind of bring this under one umbrella as kind of the house of medicine. And that's something, the American College of Surgeons, with a number of co-hosts across disciplines within medicine at the second summit for Firearm Medical Summit that happened in September, is focused on, is really trying to bring together medical organizations and then subsequently, of course, healthcare professionals that extend beyond physicians to be able to cohesively work on this hand in hand.
Thank you. So I'd like to ask for your final thoughts. Regan, Sandy, Chethan, and Joe. Regan?
Sure. I think we definitely have to take a public health approach to this. And I think Chethan or someone mentioned it earlier, but I'd really like to talk about firearms and compare them to motor vehicles. So in the 1970s, death was really common from motor vehicles. We didn't take cars away, we just made cars safer. So we developed the National Highway Traffic Safety Association. We started collecting data on why people were getting killed and injured in motor vehicle collisions. And then we worked systematically to make them safer. And now motor vehicle collisions aren't the #1 cause of death in children. And now it's guns, but we haven't done the same thing for guns and firearms. And so I think if we continue with the work that's starting right now, which is really critically looking at why people get shot, how they get shot, and then also ways to make guns safer, we really can make the community and the world safer for our children.
Thank you. Sandy, final thought?
I'm a strong advocate in knowing your community, knowing your population, and partnering with them and seeing what we can do to break down silos and organize together so that we can come to a shared vision of a collaboration. And so that we can all share in that trusted message and using that health communications approach and that population health approach to reduce firearm injury in the population and within our communities. And then looking at those messages that we've created and looking for those policy implementations that we can do, capitalizing on those approaches of where we know that we can make improvements and make those improvements within our hospital systems and within our communities so that we can work together to keep kids safe, and then work to educate our physicians, our residents, our students. We've been doing this work for quite some time, but as Joe said, we're all kind of working in our own little spheres, and how we can maybe broaden those spheres and start collaborating a little bit more together so that we can all work in those spheres in that one shared giant sphere. So thank you.
Chethan?
Don't underestimate how powerful dialogue is. And just having these conversations. And if you're at an institution that you're not sure if gun violence is something that affects the communities you work with, look into it a little bit more. Start talking to your colleagues, start talking to your leadership, seeing what's being done, start doing a needs assessment, because you're going to realize pretty quickly that gun violence, whether talking about firearm-related suicide, unintentional injury, or homicide, is an issue in all of our communities. And it is something we are all, I'm sure everyone on this call is concerned about. And that will inspire opportunities. So I just, that would be the parting thought. Dialogue matters.
Thank you. Joe?
Yeah, well, thanks so much, Liz, for having us. It's great to be among this panel. And I would just say that we briefly kind of touched upon, the structural violence piece, but I just want to underscore the fact that, when we look at the combination of discriminatory policies that you kind of layer on top of structural racism, it's really created a vicious feedback loop, right? Poverty and limited opportunity leads to increased crime, violence, incarceration, which further, I think weakens the efforts and the investment in community. And we really have to, I know we've tried to stay away from policy, but only policy can fix what policy has created in the first place. So that's going to be critical. And while this is happening, I think we as a community, need to figure out how we do all these other things that we've talked about to address, again, what I think is the most important public health problem in modern times. Because, tackling violence in cities like Baltimore is going to require a multidisciplinary approach and is going to require us to cut across sectors to make sure that the community is a central part of the solution. And I think, frankly, we're uniquely positioned as healthcare professionals and as some of us are survivors, right, who personally understand what it's like to experience violence and what it's like to take care of people on the front lines and to take care of these injured patients. We have the leadership ability to, I think, build the relationships necessary that's going to be required for us to work collaboratively across, a very complex landscape.
Thank you. And Joe, that's such an important message. As you said, hospitals and health systems with their life-saving missions are uniquely positioned to tackle the growing threat of gun violence to our children, our families, and the wider community. But as you all said today, the challenge can only be met if every sector of the community, all of us, join with you to take on this challenge. This conversation must go on, and we thank you for sharing your expertise today. Dr. Sandy McKay, Dr. Joe Saccharin, Dr. Chasen Sathya, Dr. Regan Williams, thank you for your enormous expertise, passion, insights, and guidance on what we all must do to go forward to take on this major public health challenge. Thank you.